Good afternoon, everyone. Welcome to the first webinar of our Black History Month webinar series hosted by the Office of Lifelong Learning and the Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher and I'm the Associate Dean for the office. Our office is committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Niihau, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as parts of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I'd like to go over a little bit of housekeeping for our webinars. If you have any technical difficulties or questions about L3 programs and services, please use the chat feature in the bottom of your Zoom screen. If you have a question for Dr. Salami, please use the Q&A feature of the webinar. Please review questions that have already been asked and upvote those questions you'd like to have answers. We cannot guarantee that Dr. Salami will be able to respond to all of your questions. A recording of the webinar and a Pearls for Practice document with resources will be sent via email to all of those that registered for today's event. Main Pro Plus participants may earn additional certified credits by completing a linking learning exercise. MOC and Main Pro Plus credits can also be learned by completing a personal development activity using the My Lifelong Learning Plan tool. And so for more information, please scan the QR code or have a look at our website. This activity has not been reviewed formally by the CFPC or Royal College. It is, however, eligible as well for non-certified credits. So today we're very pleased to welcome Dr. Eniola Salami, who'll provide an overview on alopecia and common trichological conditions in Afro Textured Hair. Dr. Salami is an assistant professor in the Department of Family Medicine at the University of Alberta and the inaugural Black Health Lead for the University of Alberta undergraduate medical program. She's a family physician working in a full-service academic clinical practice in South Edmonton, and my colleague. She has an MD from the University of Alberta and a BHSC with a concentration in health and society from the University of Calgary. She's a member of several national and provincial boards and is a passionate advocate for anti-racist clinical education and Black health. So thank you so much, Eniola, welcome. And thank you everyone for coming and welcome to the webinar.
Hello everyone, I'm just going to take a moment to share my screen. And I hope that everyone is able to see my screen okay. Thank you so much for coming to this webinar. I'm really excited to share this information with you and speak a little bit about a topic that I'm really passionate about. I wanted to take some time here to talk about my conflicts of interest, which has already been done, and we've already had the awesome land acknowledgement. Thank you, Dr. Campbell-Sher. And so I want to talk a little bit about my objectives for this talk. I have three main objectives that if you walk away from this talk with nothing else, this is what I want to be able to share with you. I want to be able to define and understand what textured hair is, as well as understand the reality of hair discrimination and how it affects the treatment of hair-related disorders. And I also want individuals to be able to review common forms of alopecia that affect individuals who have this hair texture. And the really good thing about this presentation is I want it to be as practical as possible. So I look forward to answering folks' questions because we want to make sure this is clinically applicable as it can be. So I want to start off with a clinical case. And so we have Callie, a second-year medical student, coming in to a busy practice, family practice. And as you begin the encounter, her eyes are welling up with tears. And for the last 6 months, she has been struggling with her hair falling out in clumps. And she has an irritated and painful scalp. She's tried everything she knows how. She's seen her braider, she's gotten some castor oil from her mom, she's been trying vitamins, she's been changing the way she styles her hair, and nothing is really working. She went to a walk-in and really felt dismissed, like was talked to about, are you stressed? Is this medical school related? And at this point she's like, I just need your help. Like, I don't know what's going on here. And so some questions I want folks to ponder while we get into the rest of our presentation is, what have you thought about when you look at this kind of a case? If it were you, what might you want to do next? And what might you use as an approach to this? And I just want you to keep that in your mind and kind of let that percolate as we move through the next few slides. So I think it's really important as we begin this case and begin this discussion to really define what we're talking about and what the cultural and social understandings of textured hair are, because it really affects how you approach your patients and how you approach this problem. So the first thing that's really important is to say, what do we mean when we say textured hair? People will often use the idea of someone having black hair or having Afro textured hair or textured hair, and that can mean a whole host of things. And it can be a bit of a misnomer. It's hard to actually get a sense of what's a true definition. Early in kind of like the 60s and 70s, a lot of dermatologists classified hair into main categories such as Asian, Caucasian, and African. And they found that this wasn't really accurate. And so we've moved away from that classification to something that's a little bit more objective. And so Lucerne is the one who really helped stratify what the different hair types are on a classification that has more to do with the physiology of the hair rather than an individual's racial background. And so types 5 through 8, are predominantly what you will see in individuals from Afro-diasporic communities. So we're really talking about that tightly curled and coiled hair. However, it's nice when we see something that is a neutral presentation, that people from various ethnic backgrounds can have those types of hair. They just tend to predominate in Black populations. And so this has represented a shift in how we define textured hair, okay? A thing that's really important for everyone to understand and that I really want to drive home is that black hair or textured hair, especially in the Black community, carries a lot of cultural weight. And that's something that I really want to drive home today, is that Black Canadians and Black people around the world, we have a very deep and important relationship with our hair. How we style our hair, how we maintain it, how we display it is not only a part of our self-expression, it's also a way that we express our racial identity. And so in many ways, it's more than just hair, right? Whether we leave our hair natural, meaning that we don't have any attachments, we don't have any things that are attached to it, or if we have cornrows, which is what's evidenced here by the lady with all those lovely braids. You can see I have braids here. These are what we would call single braids. It's a way that we express our Blackness through our phenotypic presentation. And so the Black diaspora uses hair as a means of cultural communication and cultural signifier. And that's why when someone loses their hair, it can be incredibly impactful. To add to this, hair texture has often been used as a means of racial categorization, particularly in North America, since the time of slavery. So the texture of your hair, how straight it is, how much it approximates white counterparts, was often used as a proxy to understand individuals' racial identity and racial makeup. And this had real consequences, particularly in the Reconstruction and the Jim Crow era, which is the time immediately after slavery. Your texture of your hair could determine what kind of job you had. It could determine whether or not you had access to certain social clubs in certain areas. So there's a lot of cultural baggage when it comes to how straight your hair is and how much it approximates the overall ideal of your society. Many African Americans and African Canadians have used many means to straighten their hair. There's often a straightened hair is preferred to coiled hair. And so people can use chemical relaxers. So that box of Just For Me, so that is a relaxer that people use on children. I personally had a Just For Me relaxer treatment when I was a kid. That comb that you see there is what's called a hot comb. So you would heat that up on your stove and use it to use heat to straighten your hair. Individuals will use certain combs and threading techniques to make their hair straighter. And a lot of Black patients will do what's called protective styling. So what protective styling means is that you keep your coiled hair covered, especially in places like Alberta where it's very dry. So things like using wigs, using extensions or different plaits. This hairstyle that I have here, my braids, this is an example of a protective style. My actual hair is encased in my braid to keep it away from the elements and to keep it growing and healthy. And hair straightening can be a matter of personal preference, but a lot of individuals will see it as a necessity. And this is where it's important to have a discussion about hair discrimination. And so, although textured hair is beautiful, it can be a source of microaggressions and discrimination, especially in professional spaces. And so, textured hair, locks, braids, cornrows are regularly deemed unprofessional, unkempt, and in some cases, people can even view it as threatening. The Dove Crown Act workplace study, which was a big study they did in the United States looking at hair discrimination for individuals of Black descent, found that over 20% of the respondents have had an experience where they were sent home for just wearing their hair the way it grows naturally out of their head. And there's a lot of pressure to assimilate. Professionalism and how you present in the workplace is really important. And there's a lot of bias against individuals who have natural hairstyles. And so people will often use heat or chemical relaxers to achieve a socially acceptable look. And this can be really harmful. Chemical relaxers, excessive heat, and these kinds of straightening practices have actually been associated with hair loss. And so it does have real consequences. And this picture that I have here on the slide is from a young wrestler who is in the United States who had locks, and he was actually forced to publicly have his hair cut in front of everyone before he was able to participate in sport. And so it just drives home the fact that these are things that actually affect people in real time. So what does this mean for us in primary care? What this means is that individuals with textured hair care deeply about the health of their hair. It's not just about them having, a full complement of hair from an aesthetic standpoint. It also is a cultural signifier. It's part of their identity, particularly for Black people. And it's something that actually affects how they view themselves in a deep, deep way. Many individuals have faced discrimination related to their hair. And so there can be a sensitivity towards even showing it to someone that they don't trust. A lot of people use protective styling, so you may have not actually seen your Black patient's actual hair before, depending on what type of protective styling that they use. And people tend to self-manage hair issues or co-manage them with trusted stylists or family members before they even come to you. And so if they are complaining of hair loss, they are having a serious issue with it. I know for many people in my community, when they're experiencing hair loss, their first call is to their braider or their loctician, a loctician being an individual who helps put in dreadlocks, or their hairstylist or the person who does their silk presses, and they don't even think of going to their doctor when they're experiencing hair loss. So let's go back to the case. And so as you go through and talk a little bit more with Callie, she tearfully tells you about the experience of losing her hair. And she's distraught. It's a nightmare. I can't braid my hair anymore. I don't feel or look like myself. And she talks about the resources that she's reading that are telling her to skip on braids, like don't use braids, don't use cornrows. And this is really tough for her because as a busy medical student who doesn't have time to chemically straighten or mechanically heat-based straighten her hair every day, it's not as easy for her to manage her hair, right? And she also feels a lot of pressure to straighten her hair to fit in. And has had issues with preceptors and classmates touching her hair when it's in her natural state. And she's looking at you and asking you, how can I go through and actually improve my hair health without having to give up what makes me me? And as someone who, of course, has gone to medical school, this is a huge thing, right? If you have a full head of textured hair and you have to get up before you go to medical school and heat up a flat iron or heat up a hot comb or do all these things and straighten your hair every single day, not only is that damaging, it's also an intense amount of work. And in terms of things related to hair discrimination in medical spaces, these are things that definitely happen. Even for myself, these are things that I've experienced. I've had people yank my hair, put their hands in my hair, ask me if I have dreads or this or that, people touching me without my consent or my permission. And sometimes you just don't want to deal with that. And so it's easier to straighten your hair than to have to explain to someone what's going on your head. And it happens a lot more frequently than people realize. And so when we look at Callie and we look at her concerns, we now have to take an approach to how we're actually going to assess her. And this is how I want us to actually transition into looking at alopecia and hair loss treatment for textured hair from a clinical perspective. Now that we have a better understanding of the cultural significance and how it can affect people, we want to take some time to think about how we're actually going to address this issue and looking at certain common conditions that can be helpful for people, helpful for us to know about so that we can treat people effectively. So I think it's important for us to talk a little bit about the physiology of coiled hair. And so the reason why this is important is because it helps us understand the properties of the hair that we're dealing with and why treatment of this type of hair may be a little bit different. And so coiled hair in general is very similar to other types of hair, but it does have some distinctive characteristics that will really impact how your patient cares for their hair and also your selection of treatment. And so an important thing for us to think about is that individuals with type 5 through 8 hair tend to have a more oval shape to their hair strand as opposed to a circle. They have an S-shaped follicle, meaning that when it comes out of the scalp, it doesn't come out straight, it comes out at an angle, which affects its adherence to the scalp itself, and it also creates the direction of curl growth. People with short curl diameter tend to have a lot more what we call break strain. So break strain refers to how much pressure you put on a hair before it splits or it breaks apart. And so things that have increased break strain have an increased risk of shaft breakage. So individuals' strands are a lot more fragile when you have a coiled texture. And this is important because when it's ret, it makes it even worse. And there's a lot of complex tangling that can occur. People can have knots where the hair itself ties on itself and you have single strand knots throughout your hair. You can also have a lot of complex curl patterns that can get packed together. This is part of why hair can dread. So when you make dreadlocks, you tend to create coils that wrap around each other. But when you're not intending to have a dreadlock, this can create a lot of tangles. And an important thing to think about is that how we moisturize our hair is that the sebum secreted from our scalp goes along the hair shaft and allows it to moisturize. When you have a circular pattern, it's harder for that lubrication to happen. And so individuals with curl patterns that are tighter tend to have drier hair. And that's why a lot of Black patients who have Afro textured hair tend to actually protect their hair, is to keep the moisture on the hair strand to improve its health. Now, an important thing that I think a lot of physicians can benefit from, and healthcare workers of all stripes, is knowing how to ask about these things. Because oftentimes this isn't something that comes up naturally in conversation necessarily, or when it does, it's nice for us to have an approach and a bit of a plan of how we're going to have a detailed conversation about hair. I think it's really important to talk about it in terms of the 3 Ps. We have practices, protective styling, and past history. And this is a good way for you to remember some of those specific questions that may be applicable to individuals with this type of texture who are in the Black diasporic community, or individuals with this type of texture from any community, right? So how do you generally care for your hair is a great way to open up this conversation, because often for a lot of individuals who have type 5 through 8 hair, and particularly individuals who are from Afro-diasporic backgrounds, these are often really detailed regimens. So a common thing that people talk about is their wash day. And so individuals will wash their hair on a particular day of the week or wash their hair once or twice a week. And they often have a regimen or a way that they not only cleanse their hair and scalp, also how they condition their hair and imbue moisture into it, what kinds of products they use, oils, natural tinctures, whatever it is, to help maintain the health of their hair. And so it's important to understand, how frequently do you wash your hair? How many wash days do you have per week? What kind of products are you using? To get a sense of what they've actually tried that's non-pharmaceutically involved, right? Another important thing to know about with practices is whether or not individuals are using chemical relaxers, keratin treatments, or straight perms. And so, as I alluded to early on in the presentation, individuals who prefer to keep their hair in a more straight pattern can use chemical relaxers either at home or in a professional styling context to keep their hair permanently straight. So what a relaxer is essentially a basic compound that breaks the disulfide bronze down in your curls to make your hair permanently straight. And so the ends that you straighten will be straight forever, but your new growth will grow in with your natural curl pattern. So people will have what's called a retouch, where they actually re-relax their hair. And these relaxing processes can actually weaken the strand itself. And so breakage and irritation can happen. You can also have irritation from the basic compounds touching your scalp as well. And that can aggravate and exacerbate existing hair loss. So knowing about those things is really helpful to let you know about what may be happening behind the scenes that you don't see before they come to your office. Protective styling. So asking about weaves, which is when you actually cornrow your hair and attach attachments to it to give the appearance of having longer hair. Sew-ins, which is another variation of attaching hair that involves braiding and using sewing to actually keep it onto your head. Dreadlocks, which a lot of people have seen. So if you see in this picture, the lady who is creating the hairstyle, she has dreadlocks, where you allow your natural hair to, in an organized pattern, pack around itself to create those things. You have braids, which you can see on my head, wigs, high ponytails where you can slick your hair back and attach it. So there's so many different ways that individuals can protect their hair. And so it's good to know what an individual is using, and it's good to know that, am I actually seeing your hair when you're sitting in front of me, or is your hair in a different state than what I'm seeing? I think it's also important to focus on the application of these extensions, because how tight they're attached, how they're attached, whether there's glue or bonding materials being used, threading, sewing, if it's braided in, these are all important things to let us know what kind of strain is the hair under. And an important thing for us to think about is what's called tension. So a lot of these styles, including the style you see on my head, involves the pulling and the braiding and weaving of your hair. And it's really important to understand how tightly an individual applies a style to their head. Generally speaking, you want your hair to be non-painful, right? But it's very common for individuals to ask for styles to be applied tighter so that they last longer. And so it's important for you to understand whether or not an individual who's using a protective style is using one of the ones that can be related to having higher tension. And so things like feed-in braids, which you're seeing depicted in this picture, where an individual is using extensions along with their natural hair to create a style. Cornrows, smaller braids, frequent retwists of dreadlocks. So individuals who have dreadlocks will have the parts redone and will have them retwisted to keep them from dreading together and to keep them separate for the style to be maintained. And that also puts tension on the hair follicles as well. For past history, you really want to focus on if they've had any prior hair loss, if there's family history of hair loss. Their shedding and their breakage level. So are they seeing shedding, where you can actually see the bulb of the hair on the end and it's actually coming straight from the scalp? Or are they having hair fragments showing that they're having mid-shaft breakage? And you all, of course, want to ask about irritation, redness, scabbing, or itching. From a clinical examination standpoint, the best case is for you to examine hair that is loose and in its natural state. So you want your patient to refrain from washing their hair immediately before the appointment, as this can complicate the interpretation of any pull testing that you do. And you also want to make sure that their hair is in as much of a natural state as it can be. So if an individual is someone who wears a wig, you would ask them to come without it or be able to remove it before you do the assessment. If an individual tends to have braids, it's helpful if they have a braiding style where you can actually part the hair and actually see and access the scalp. Or if they have dreads where they're able to take it down from an updo or from a braided state so you can actually see the scalp. The first thing you definitely want to do is overall look at the pattern of hair loss. And this is very consistent with your normal assessment of hair loss in general. So getting a sense of where is the distribution, how much is being lost in each area, getting a sense of particularly the temples, the crown, the nape, Often when individuals from Black communities talk about their edges, they're talking about this portion of their hair here, their edges. And so that's something that you can ask people about in terms of like, are you losing your edges, is a common thing that you'll hear people say. And you also want to look for those distinct patterns, right? For a breakage assessment, this is where you want to do what's called a pull test. So you will take a piece of paper or something white or a contrasting glove, and put your hands under a thin layer of the individual's hair. And you're really looking for if there's any signs of breakage along the hair shafts, and if there's any complex single strand knots that you may see. And then you'll take one strand of hair and then gently pull to see if you have an immediate shed or if you see that there's breakage in the actual hair shaft. And this can be helpful in terms of diagnostic clarity, which we'll get into as we get into the various conditions. And another thing that's helpful is dermoscopy. So actually looking at the scalp under dermoscopy to look at the intrafollicular distance. So looking at how far the follicles are from each other, getting a sense of inflammation or if there's any scaling or plaque formation. This can be very helpful in helping to distinguish what kinds of hair loss you're dealing with. So when we talk about the alopecia that affects individuals of Afro-textured hair, by no means is this going to be fully comprehensive and looking at every single condition, but I wanted to highlight some of the key ones that are really helpful for us to know about as we treat individuals from this group. And in particular, I want to focus on CCCA, as well as lichen planopilaris, as well as folliculitis keloidis, okay? So the first one that I really want to focus on is CCCA. This is a very common scarring alopecia that affects Black individuals with type 5 through 8 hair. And what I really want to hit home for CCA is that the early symptoms are when you have the most impact. So knowing about the early symptoms is really, really important. So hair breakage at the crown or shortening hair at the crown is often the first symptom that individuals will see. So they will start to see that their hair shafts become thinner and smaller, what we call follicular miniaturization, and they will have increased breakage in the center of the head. They will often have hair thinning at the crown, which you can see in that top picture of that lady with the braids, where you can see at the crown she's having this increased space and the hair looks more vellus and a lot thinner. People will often have itching, burning, and as well as scalp tenderness in the area. This is another early sign of the inflammation taking hold. Later, as the condition takes hold, individuals will start to have a shiny atrophic scalp with bald patches. And this is where we have less ability to restart hair growth in those very severely affected areas. And so we often want to catch things when people are having hair breakage at the crown, hair thinning, burning, and tenderness, because that's when we have the opportunity to actually save some of those hair follicles. Risk factors for CCCA are still being studied at this time, but the most common thing that has been associated with it in the past is chemical relaxer usage. So as I earlier talked about, some of those straightening practices actually have health effects for people. But they're increasingly showing that genetics may play a role in CCCA, that there actually may be genetic components, and they're more classifying it as an actual autoimmune condition rather than something that is simply related to hair practices. CCCA used to be called hot comb alopecia because they presumed that it was all due to hair practices, but as we've been able to progress in our studies, we have seen that there's actually an inflammatory cascade that's involved in the actual manifestation of CCCA. So on a clinical perspective, you're going to see erythema, scalp tenderness, hair miniaturization. You may see a perifollicular halo on dermoscopy, meaning that you'll see a whitened area around the affected follicles that show the sclerosis and the inflammation. You may see what's called polytrichia, where you have multiple hairs coming out of a singular follicle, and broken hairs and shorter hairs at the crown. The most important thing that I want to highlight about CCCA is the fact that dermatology referral that is prompt is key to preventing permanent loss. Time is scalp. So this is an inflammatory scarring alopecia. The quicker you can get someone to have a scalp biopsy that's confirmatory, the better off your patient will be. Now, in terms of the ways that CCCA is treated, there's a multitude of ways that individuals can treat it. The most common thing is steroid treatment. So individuals can have topical therapies or injectable therapies, pardon me. So injected triamcinolone. Individuals can also be placed on antibiotics, so anti-inflammatory antibiotics of the tetracycline variety. Calcineurin inhibitors have also been used to treat CCCA. And for individuals who have significant disease, there's even been studies where individuals use cyclosporin, as well as hair transplantation once inflammation has been treated. Interestingly, there have been new randomized control trials that have been using topical metformin in conjunction with clobetasol that have shown increased effect for individuals with CCCA that is mid to late stage. So you may actually see the dermatologist prescribed topical metformin and clobetasol, but some of the different formulations on this page are things that you can start your patient on as they await getting dermatology referral. Now, lichen planopilaris is I would say a cousin disease to the previous condition. And it really is where you have a lichen sclerosis effect on the scalp, essentially, is the shorthand for this condition. People will have patchy multifocal hair loss. They'll have a lot of itching and tenderness, and they'll have a lot of scaling and plugging around their hairs. So when you see this picture, you can see the buildup and the flaking around the hair exits from the scalp, and you can see that there's thick plaque formation as well. And you can see some of the post-inflammatory hyperpigmentation there as well. The scalp biopsy is the gold standard for diagnosis, and often this can look very similarly to CCCA. It's one of the key differential diagnoses, and so you would be well in hand to approach it in a similar way. As I said earlier, time is scalp, so referring for scalp biopsy and therapy initiation is incredibly important. And much like CCCA, a high potency or super high potency topical steroid plus or minus intralesional steroid is your go-to for treatment. Some individuals, if they have systemic manifestations, for instance, if they have lichen planopilaris on their head, as well as lichen sclerosis in other areas, may be on systemic corticosteroid or hydroxychloroquine. Now, folliculitis keloidalis is a particularly important condition for people to know about for individuals who use a barber or have barbed hair. It's when individuals will often have papules and pustules, and the nape of the neck is the most common place for this to occur. This has also been referred to as folliculitis barbae as well, because it was something that was seen very typically in individuals who had textured hair and also frequently had a close cut on their nape. And so it can cause papules, pustules, itching, and burning, and it really can be increased in individuals with curlier or coarser textured hair, individuals with seborrhea, and individuals who have hidradenitis suppurativa. So this can also be a part of a more systemic HS picture as well. The papules and pustules tend to be very painful, and as you can see from this picture, they tend to coalesce, so they can become large abscesses as well. People tend to have a lot of hyperpigmentation and pigmentous changes, and they can have thickening of the skin and even raised keloid scars. And so this is something that is a clinical diagnosis. However, individuals can actually use a scalp biopsy for this as well. But the most important thing is to avoid picking or scratching this area. And it may be helpful for the patient to reduce their barber frequency. You want to treat secondary infection for this condition. So a lot of individuals who have these papules and pustules, they will get secondarily infected, whether it's an impetiginous infection or if individuals have abscesses that form. So topical antiseptic washes and oral antibiotics when needed is a mainstay of therapy for this condition. And a high potency steroid and a retinoid is the main way that we treat this condition. So topical clobetasol with adapalene or injected triamcinolone is another way that you can treat this. Oral tetracyclines are also helpful, and we've also seen individuals respond well to the removal of keloids with surgical management, as well as UV therapy. So UVA, UVB therapy has also been used in this condition. Dissecting cellulitis is also another condition that can affect individuals with textured hair who have a close shave or a close cut. And so in this case, you will see diffuse tender papules to the scalp, but they tend to be bigger and more diffuse in where they occur. Individuals with this condition tend to have coalescing sinuses. So when you look at this picture, you can see that there's these raised ridges. So these are essentially where the papules have formed these tracts that occur underneath the skin. People will have diffuse hair loss because this is something that occurs in the dermis and really disrupts follicular growth. It can look a lot like acne conglobata, but on the scalp itself. And I know that for a lot of individuals who have seen this on the face, you can see it also in a similar pattern on the scalp. So a clinical diagnosis is important for this, but a scalp biopsy is often necessary so you can see the inflammatory changes in the dermis. And so a prompt dermatology referral here is important because this can cause a lot of hair loss very quickly. And so for mild conditions, you can use topical antiseptics and tetracyclines and injected corticosteroids. But for moderate and severe cases, people actually respond really well to isotretinoin, so actually going on Accutane, as well as tetracyclines and rifampin. And in really serious conditions where individuals have multiple areas of scalp affected, they can even have skin grafting because this can be very diffuse and can cause the global loss of hair very quickly. And last but not least, I want to talk a bit about traction alopecia. So as you heard earlier in the presentation, tight styles can be related to hair loss. And traction alopecia is a very common thing that you can see in individuals, especially people who use braids, locks, who pull their hair back. And you will typically see it in the frontal areas, the temporal areas, and at the nape. But it can occur anywhere in the scalp where the scalp is under constant tension. The most common thing that you'll see is individuals having pruritus. They'll have itching and they'll have a tender, painful scalp. This will often be temporarily located to when they have their attachments added. So you may see individuals having white papules in the areas of increased traction as you're actually seeing the hair being pulled from the scalp. They may have burning or pain after their hair is fixed into a particular style. And so on the clinical side, you're going to see erythema, pustules, and folliculitis is also something that you can see. You can also see broken or shed hairs in the areas of tension. And in the early stages, you'll have increased telogen and catagen stage hairs. So baby hairs is another way that people may refer to that. And late, you're going to have vellus hair and fibrous tracts where you're not going to have any return of the hair after it's being pulled. Diagnosis can be something that you can see clinical. However, this can look like frontal fibrosing alopecia. And so you want to make sure that you do a scalp biopsy before you simply assume that the pulling is what's causing the hair loss. A change in hairstyling is the number one thing for this. So really focusing on low tension styles that are looser and put less tension on the hair is important. Switching your hair braider or your loctician will be important. Individuals who have an early stage of this alopecia or in relation to a style can also be advised to take that style down or to take the areas down that are on tension. And giving a topical antifungal or topical antibiotics to treat the folliculitis that can result from this is important to prevent lasting inflammation. For individuals who have loss like this that we see in this picture, trying topical minoxidil can be really helpful. The foam, however, can be very drying, so you want to advise your patients with textured hair to ensure that they're effectively moisturizing while they're using these products. And hair transplantation, of course, is a definitive treatment for individuals whose hair and scalp does not respond to the minoxidil treatment. So something that I think is really important for us to think about is, yes, there's these conditions and yes, there's pharmaceutical management, but there's also conservative management, which is the bedrock. Good basic hair care is the foundation on which all of these different treatments rest. So it's important to tell your patients that they should see a licensed stylist who specializes in textured hair. It's a particular way that this hair needs to be cared for and treated. And so individuals who don't have the actual expertise can actually damage people's hair by using too much heat, using the wrong chemicals, using the wrong practices. So having an individual who has experience with this type of hair can help you quite a bit. Washing your hair every week or every other week using a sulfate-free shampoo is often something that is the bedrock for a lot of treatments. Some people may wash their hair a little bit more frequently, but stripping the hair of moisture a little bit too frequently can increase the risk of breakage and dryness to the scalp, which is not great for textured hair. Using a conditioner is really important. And so individuals with textured hair, as you know, tend to have drier hair that's more fragile. So imbuing it with moisture is really helpful. And you want to balance imbuing it with moisture with also things that imbue it with protein to help rebuild those sulfide bonds that give you that curl pattern. And so having a conditioner that balances both is really effective. Avoiding a chemical relaxer when possible is really helpful. As I said earlier and multiple times in the presentation, it can cause scalp irritation, burns. It can also increase your risk of hair loss. So as much as possible, if people are able to refrain from it, it's really helpful for them, especially if they have these inflammatory conditions. Using heat judiciously also comes with that as well. Heat breaks down bonds, but it also effectively cooks your hair. And so if you can avoid that as much as possible, it's really helpful. And ensuring that extensions, wigs, and weaves are not too tight. And so for myself, as you can see, I have a braid job here. I really know I've got a good braider when I leave her chair and I have no pain. And I know that can sound a little bit like, why would you have pain? But for a lot of us, that's something we've grown up with just having braids that are just really tight. And so I've been very careful to find a braider where I can get up from her chair, throw my hair in a bun, and I don't feel like I have a million different hands pulling at my scalp or an instant eye lift. As some people may see, right? You don't want it to be too tight. And of course, you want to encourage your patients to feel comfortable speaking to you about their hair loss, and that time is scalp and time is hair, and that you're going to take them seriously and refer them on to dermatology. So I really like to let them know that if you have itching, burning, scaling, hair loss, let me know about it so that I can help you on time. So as we return to our case, you examined Callie's scalp and found a central area of hair loss with erythema and irritation. You suspect CCCA and you start her on topical clobetasol and send her to a dermatologist. She has a scalp biopsy and your suspicions are confirmed. 3 months later, Callie follows up in clinic for a refill of her shampoo and she's beaming. Although the shots that she's had in her head of triamcinolone are painful, she's had a great improvement in her hair. She's not seeing any more hair fall, her irritation is gone, and she's been careful to use low tension styles, but she still feels like she can be herself. She appreciates that you didn't just tell her that she can't wear braids anymore. And she really is feeling a lot of relief and is extremely thankful to you for helping her. So excellent job, everyone. So what are the key messages here? The care of textured hair is deeply personal and it's extremely connected to cultural and racial identity. And so it's more than just how we present in terms of, oh, this looks cool. It's also a signifier a little bit about my identity, what the underlying texture of my hair may be, how I want to be in the space. It's about how I project my identity to you. Doctors are often the last people to hear about hair loss for this population. It's just something that people don't necessarily talk about. So opening up the space for it is really important. Time is hair, so you don't want to delay your scalp biopsy or dermatology referral as much as possible. And treatment suggestions really should take into consideration common hair care practices, because that's really the basis on which you're going to build your regimen. And of course, you want to have effective conservative management. That's important to lasting results as well. And those are my references. Thank you so much for your attention and time.
Awesome. Thanks a lot, Eniola. I'm just going to remind folks, please pop some questions in the Q&A. No, I mean, I have a bunch. So, Eniola, is there any trick to doing the scalp biopsy? Is there a reason why? Is it different than any other skin biopsy that we do? Can we do it in the office to get a jump on it?
Yeah, so you can do a scalp biopsy in the office. So it's a simple punch biopsy of the scalp. Usually individuals will take 2 4-millimeter punches. And so usually when you're doing this, you just reassure the patient that we seal up the hole because people will often be like, I don't want to have a bald patch. So I always assure them that I put a single Prolene stitch in there to put it back together. And so, yeah, you want to get down to dermis because you want to be able to catch any inflammation that's in the dermis. In Edmonton right now, dermatopathology for scalp biopsies is taking around 6 to 8 weeks, so it takes quite a bit of time. So I always like to tell patients about that as well. And you want to take the scalp biopsy in the area which is most affected. So for instance, in CCCA, you want that to be at the crown. If it is at the actual nape, you want it to be at the nape. And so you want to take two samples, and you want them to be within the affected area, but you don't want them to be exactly next to each other. So often what I saw when I did my dermatology elective is that they would take one spot and then they would go 4 millimeters at a diagonal from that spot and take a second sample and send them both. That way the pathologist has a comparator. And it is helpful if you can get an actual follicle in your biopsy as well, so that they can see the follicular base and the shape of the shaft. But if you're not able to, or if an individual has extensive loss, you should just go in the area that's most affected. Yeah.
Very cool. Awesome. Okay, so Agoma's got a question. So first of all, Alexandra says, very interesting. Thank you very much. So thanks, Alexandra. And folks, please put the questions in the Q&A. Nia, I'm talking to you. I see you in the chat. So Agoma's got a question here around how do you treat seborrheic dermatitis in someone with braids?
So this is actually a really good question. So for seborrheic dermatitis for an individual with braids, the nice thing about it is that you have access to their scalp. As you can see my scalp. And so I often tell people to use a topical antifungal shampoo as the basis of their treatment. So something like a Nizoral or a topical ketoconazole shampoo is very effective. It's also important to note that when you have a braid, so I don't know, I can't see myself, but you can maybe see my braid. So my hair pretty much ends like probably around there. And the rest of this is just plastic, basically. And so the washing is really like here, right? So I usually tell the individual to wet their actual roots. So this is what we refer to as the root of your hair. And then to put on the Azole shampoo or put on the Nizoral and let it sit. And then to actually wash in between the grids. Right? Using a finger, you want to make sure that their nails are not sharp, because you can actually cut your scalp and hurt your scalp. And they're just going to do a gentle circular motion to let it sit and let it wash out. And that is often very effective for individuals with braids. An important thing for people to note is that individuals with braids do wash their hair. Like I still wash my hair. And so you just want them to incorporate that into their regular routine. And again, these shampoos are very drying. So you want the individual to replace their moisture. Most individuals with my type of texture of hair will use either a lightweight oil or a cream-based leave-in conditioner as a means of keeping their roots from drying out. And so that is something that they would do at the back end as well.
And Eniola, just a follow on for that, how often do you take down the braids?
Yeah, so this is actually a really good point. You should not have your braids in for longer than 8 weeks. So 2 months is really the maximum, because as you have new growth, it can kind of tangle around itself at this root. And so you also don't want the weight of the braid to be pulling on your new hairs that are growing in. So I usually advise patients that 2 months is really the maximum you should keep any protective style where you have an actual direct attachment. If someone is someone who wears a wig that they actually apply with glue, so what people will do is they will glue the false hairline ahead of their hairline and wear it. That is something that I would say you shouldn't have longer on your head without removing than 2 weeks. But if you have a wig that you take on and off, of course you remove it every day. That's my favorite part of the day when I have that, is just whipping it off, sometimes in the car if I'm in a rush. But if they're taking it off on and off, they don't have to have too much of an issue. But if it's attached, 2 weeks if it's covering their whole scalp, and if it's braids, 6 to 8 weeks at the maximum.
And Ogoma has a follow-up question just on this theme around, what about patients with weaves and seborrheic dermatitis?
Yeah, so that makes it a lot more challenging because it depends on how the weave is affixed. So you can have what's called an individual wefted weave, where an individual has a bunch of cornrows, where they can basically approach it the same way an individual with braids does. But if an individual has what's called a quick weave, where they essentially braid down their hair, put a net on, and then sew the wig to the net, they don't have access to their scalp. And so if you have a patient who suffers with seborrheic dermatitis that's very severe, you would advise them to actually stay away from things called quick weaves and make sure that they have access to their scalp so they're actually able to cleanse their scalp effectively. And so that's where you have that discussion with the patient around, what kind of look are you trying to achieve? And is there a way that you can achieve it where you can consistently cleanse your scalp?
Okay, awesome. Now we have a couple questions about children. So
Mhm.
first of all, Maya's just wondering about whether topical clobetasol is safe in younger children.
I would say no. You don't want to use a high potency clobetasol in a child if you haven't consulted pediatric derm. So I personally don't see a lot of individuals with these conditions who are pediatric. But if I were to see an individual who had signs of inflammatory alopecia that I would be concerned for, I would want to involve pediatric dermatology early for guidance on that, precisely because I don't want to use too high potency of a steroid on that patient. Plus, some of these conditions that require treatments like lesional triamcinolone and injections would be a lot more challenging in a pediatric population. And so what I would recommend if you see an individual who is pediatric, especially a younger patient with these kinds of conditions, is to involve pediatric dermatology earlier rather than later, and then to actually have them guide the potency of steroid you could use. And in general, when I looked at the actual data, there's very few studies that look at high potency steroids for the pediatric population. Most of them advise changing styling practices, referring to pediatric derm early on, and using lower potency steroids. So things like hydrocort or Betaderm rather than doing a clobetasol.
Mhm. And then Cree, thanks so much for sharing, is presenting. My child is 7 years old and has alopecia universalis. We've stepped away from dermatology and are currently working with a naturopath, where some underlying imbalances have been identified. From a holistic perspective, what would you suggest is the most important next steps to support immune regulation and overall health in a child with alopecia? And I know we have also pediatric colleagues on the webinar, so feel free to chime in if you've got also some thoughts there, colleagues. But Eniola, do you have some thoughts for Cree?
Yeah, I think that I mean, obviously, I want to be cautious in that, like, each individual case definitely has to be followed up with an individual family doc who knows the patient well. But in general, when I think about holistic care, I think that the bedrock for sure would be making sure that you are having a nutritionally dense diet, that you are, doing all the basic things that you would do for well child care for pediatrics. So ensuring that an individual is getting enough iron-rich foods, they're having a diverse diet, they're otherwise taking care of their health in general. In terms of immune regulation, that's not really my area of expertise, so I'm not exactly sure if there's anything particular that I would offer from an allopathic perspective that would relate to that. I think that you would want to look with an individual patient what immune concerns there would be and do a thorough history and a thorough assessment to see if there's other concerns. But I think that having overall well child care that's really stable, as well as having those really good care practices for the hair, would be what I would recommend. Just keeping in mind that I'm viewing this from a purely allopathic lens, right? But that's really what I would offer in regards to that.
Yeah,
Yeah.
great. Yeah, thanks so much, Cree, for sharing. Angela's just also saying thanks for your presentation, and is asking, when textured hair is cut, are there cultural or spiritual ceremonies around the cutting or around the hair that's cut off?
Not that I think it's really hard to say like universally because textured hair and your ethnicity and your cultural practices are kind of two separate things. So for some people that very may well be the case, right? Where their cultural practice or their religious practice will determine what they do with their cut or shed hairs. And for other people with textured hair, they don't have the same relation to it. I think what I would say is have the conversation with your patient, right? I think it's really cool to be curious when it comes to this and say, hey, like, tell me about what your hair means to you. How do you handle your hair? When you cut your hair or you have shed hairs, how do you handle those? Because you will have a thousand different answers if you ask 1,000 different people with textured hair. So I think it's a really good opportunity for you to open up a way to relate to that patient, right? And to ask that question. But there's no universal process that you can see because the people with textured hair in the world are in the billions, right? And they cross-sect so many different parts of the world and so many different cultural practices.
Awesome. Thanks so much for that. And Kriya is saying thank you. And just to follow up actually on that point, Anila, could you provide in the pearls some basic tips and products that you would find helpful in Edmonton that people can maybe think about? Because I'm thinking, sometimes we might have people who've come from away, from a very different climate, for example, maybe where very different products were needed because the environment was so different, and here is so dry. Um, is there some best practices for like living in Edmonton where it is so incredibly dry that you could share?
Yeah, of
Like, would
course.
everybody know that, do you think? Or is that something where people might not know when they first come from away?
Yeah, I mean they may not know. Definitely, like when I did this presentation in person previously, I actually brought in all my products. I came in with a basket of products, and so yeah, I definitely recommend to individuals different products that they can use at different price points. I also find that for many of us, the first thing that I figured out when I came to med school here is where's my braider, where's my hairdresser, and where's the beauty salon or beauty supply, right? So this is often something that we whisper campaign, we tell each other, right? And so yeah, I definitely have a resource of places where people can go and things that people can use that are fairly inexpensive as well. So that can be provided as well if people want to make recommendations. But 9 times out of 10, your patient probably has an idea, but if the event that they don't, it would really be awesome for you to be able to be aware enough to provide that. I think that would be really like rare. I've personally never experienced that, so that'd be really cool.
You're going to make us all smarter, Eniola. And just a shout out for the Black Health Fair last year. It was really great. And I think you guys were doing some topics on this. What other things did you hear from the community around things that maybe we should let people know related to this topic, if there was any other bits or pieces that came up in that venue?
I think what's really stood out to us, and part of the reason why I'm doing this, is that a lot of people just don't know about this topic. And it was very clear that a lot of individuals had either never spoken to their family physicians about it, or had never been asked about it, or that there was a general lack of awareness. And so that's really the main thrust of this presentation, is for people to be aware. And really another thing was really having people understand what hair discrimination is and what it means, and how so many people have a lot of really negative experiences in the way that people view them and view their hair. And so having doctors and healthcare providers and learners be sensitive to how these things can affect people day to day was another really big message we got.
Oh, that's awesome. Well, I think, guys, we're coming right up to the hour. But just want to really say thank you to Eniola for coming and for sharing, and excited for all the upcoming webinars. So little plug for the rest of the series this month. Hopefully we see everybody. And if you're interested on updates about things, please subscribe to our newsletter. And then do we have an evaluation in the background, Natasha, as well? Yeah, there we go. So thanks, Natasha. So, and here's a QR code. Really appreciate your feedback. And then we always are interested in additional topics and things people are interested in. So if you have a minute, please take a second and scan the QR code and provide some thoughts. Awesome. Thank you so much, Anila. Great. And thanks everybody for coming. And perfectly timed.
Thanks everyone for coming.
That's awesome. Super cool.